So we're in the middle of an exploding, increasing epidemic of diabetes, and a lot of patients with diabetes get renal disease. Frequently, nephrologists will just say this is probably diabetic nephropathy and not go any further. But there's a list of things that causes them to sort of raise their hackles and get worried that something else might be going on. This includes the rapid increase in creatinine or proteinuria, so renal failure and nephrotic syndrome. Hematuria, you can see hematuria in diabetic nephropathy, but it's not particularly common. You have a patient who's got renal disease with diabetes and doesn't have other end organ manifestations, so no retinopathy, no neuropathy. Have a patient who's got diabetes but relatively well controlled and they have nonetheless developed renal disease. And finally, you'll occasionally get patients who have unexpected serological abnormalities, anti-nuclear antibodies or anti-neutrophil cytoplasmic antibodies, low complement levels, sometimes evidence of a viral infection. So when patients have one or more of these things, they will sometimes get a biopsy. And those biopsies can show one of three things. First is, and probably the most common, the patient just has diabetic nephropathy after all. Every now and then you'll get a biopsy that shows something entirely different and unexpected. And then the third category is patients who have more than one thing. They actually do have diabetic nephropathy, but something else is added on top of it. And I'm delighted to see Cindy Nast in the audience today. Cindy is one of the editors of the journal Glomerular Diseases. And she invited me a couple of years ago, after hearing a GlomCon conference that I gave, to submit a paper to that journal on pitfalls of diagnosis of glomerular diseases in patients who have more than one thing. So I want to thank Cindy for her encouragement and mentorship in writing that paper, and I'm delighted that she's here at this conference. So I'm going to show you some illustrations of this with a series of cases from my own files. The first of them is a 61-year-old female with mild chronic kidney disease, and she'd all of a sudden had a dramatic increase in proteinuria. Her urine protein creatinine ratio went up to 10 grams per gram. She had a history of diabetes. She's quite large, had a body mass index of 55. And she also had a history of recent use of non-steroidal inflammatory drugs. So here's her biopsy. And at low power here, you can see some glomeruli that look like they have too much eosinophilic material in them. This is a higher power view of the glomerulus. The cellularity is relatively normal, but there's too much pink stuff. And here's this pair of special stains that we do. I showed you in the talk I gave yesterday in a different context. But this is a PAS stain for carbohydrates, stains the capillary loop basement membranes and mesangial matrix. And if there are immune complex deposits, it'll also stain those. And the mesangial areas here look expanded, relatively hypocellular. So there's a little nodule there, another one there. And the silver stain is a stain for basement membrane and matrix material, and shows basically the same thing. Capillary loop here, maybe a little bit thickened, but sort of hard to tell with this stain sometimes. But then the main thing is these mesangial nodules. This is sort of a young Kimmel-Steele-Wilson diabetic nodule. All of that looks pretty good for diabetic nephropathy. Here's the electron microscopy, and we see capillary lumen, mesangial area, urinary space. And if you notice the bar down at the bottom right is 4 micrometers, and some of these basement membranes are maybe at least a fourth of that. So this is like a micron thick. A normal adult basement membrane is about 350 nanometers. So that's 3 times as thick as it should be. And that's a cardinal finding in diabetic nephropathy. And this gray stuff over here is mesangial matrix material. This is much bigger than it should be. So this is sort of a ultrastructural view of a small Kimmel-Steele-Wilson nodule. So all of that looks fine for diabetes. There's nothing that looks like any kind of deposit. But if you look out here on the outer surface of the basement membrane, the podocyte foot processes are almost completely effaced. You can see a few of them sort of hanging on for dear life here, but there's very widespread podocyte foot problems in the basement. And here's a higher power view showing the same thing. Foot processes here almost gone. and here. Basement membranes, again, look thick, but there's no evidence of any kind of deposit. Here's immunofluorescence. This projection is quite bright, and it does look like there's sort of linear staining for IgG. And you might think, oh my gosh, does this patient have anti-glomerular basement membrane antibody glomerulonephritis? But notice that the staining for albumin is equally intense in this linear pattern. This is a characteristic finding in diabetic nephropathy. It's just insudation of serum components into those thickened, damaged basement membranes. No staining for complement components, and the kappa and lambda chains also show this sort of weak linear staining pattern. So this patient does have diabetic nephropathy with nodular glomerulosclerosis in the renal pathology system. This is a class 3, sort of in an early phase. But there's also severe podocyte foot process effacement. Now you can see foot process effacement just in uncomplicated diabetic renal disease, but this is a little more than you usually see, and it's probably correlated with this rapid increase in proteinuria that this patient had. And both NSAIDs and obesity can be predisposing factors to podocyte damage. So I think this patient probably has either an NSAID nephropathy or obesity-related glomerulopathy. And she was encouraged to stop taking NSAIDs and try to take steps to lose weight. Okay, moving on to our second patient. This is a 35-year-old female, nephrotic syndrome, so heavy proteinuria, normal renal function. She had had diabetes for about 5 years. She had a history of urinary tract infections, and she had also occasionally used NSAIDs. So here's her biopsy on H&E stain at medium and high magnification. Here, the nodules are more conspicuous than they were in the previous case. And again, the material is strongly positive on PAS and Jones silver. So this pathogenesis of diabetes involves non-enzymatic glycosylation of tissue components, including matrix material and basement membranes. So matrix is PAS positive to begin with, and it has even more reason to be PAS positive because it's got extra sugars stuck to it. Here's the electron microscopy. Again, the basement membranes look somewhat thickened. The bar here is 2 microns, and some of these look like they might be half of that. So again, maybe up to a micron in thickness. The mesangial matrix here is expanded. But if you look carefully, there's something else here. There's some dark granular material down here in the corner. And here's another view that's centered on the mesangial area. This is a Kemmel-Steele-Wilson nodule, but we got this dark granular stuff here. It doesn't have any notable substructure to it. It just looks like an immune complex. And sure enough, on the immunofluorescence stains, there is fairly bright granular staining for IgA in these little polygonal clumps, which is a characteristic appearance for mesangial immune deposits. A little bit of C3, and there's staining for both kappa and lambda chains, but more lambda than kappa. And that's all very characteristic of IgA nephropathy. This patient's got another RPS class 3 diabetic nephropathy with nodular glomerulosclerosis, but also IgA nephropathy. And it's sort of fairly inconspicuous and at probably an early stage that the clinicians would probably not consider treating. But remember, in this day and age, we have an increasing number of medicines that can be used to treat IgA nephropathy. So they need to know this in case the nephropathy gets worse. It also tends to recur in transplants if she ever gets a transplant. So it's a very important thing for the clinicians to know. All right, moving on to a third patient. This is a 45-year-old female. She's got a modest increase in creatinine and yet again, nephrotic range proteinuria. This is one of the more common things that brings them to biopsy in the setting of diabetes. Her diabetes was poorly controlled, and she also has an elevated body mass index. So here's her biopsy, and sort of third verse, same as the first. We see nodular areas of expansion of mesangial areas, seen over here, here, kind of similar here. Nodules, relatively hypocellular or even acellular. And you can also see them on the Jones silver stain. But yet again, electron microscopy shows something unexpected. The bar down at the bottom right is 2 microns, so these are certainly thicker than they should be. But over here in the mesangial area, there's just this sort of large expansion by granular stuff. Looks kind of like the deposits we saw in our IgA nephropathy case just a second ago. You had to look around for them, but there were occasional subendothelial deposits of the same thing, and maybe here even a little subepithelial deposit that's getting encased in basement membrane material. So it looks like some kind of deposit. In contrast to the previous case, this has really strong staining for IgG in the mesangial areas and a little bit less along the capillary basement membranes. This stuff has fixed complement to a striking degree. There's strong staining for C3 and C1q. And there was a little bit of staining for kappa and lambda chains, but it's much less than we saw on the IgG stain. They're kind of equivalent. And I thought, well, I would have expected to see more. And so I had immunofluorescent staining for kappa and lambda chains done on some pronase-treated paraffin sections. And so in the upper panels, this is just the frozen section IF that I just showed you. This is the immunofluorescence on paraffin, and there's very strong staining for kappa chains, but minimal staining for lambda chains. So this sort of aroused suspicion that this was some sort of monotypic deposit. Based on that, I did immunofluorescent staining on the frozen tissue for IgG isotypes 1 through 4. And this stuff is exclusively IgG3. So this patient has got nodular glomerulosclerosis, but has also got some sort of immune deposition disease that fits best for proliferative glomerulonephritis with monoclonal monotypic IgG3 kappa deposits, or since that's a mouthful, PGN-MID. And there's actually, particularly for the IgG3 kappa subtype of this, there's good recent evidence. There's a paper that Sami Nasser is one of the authors on that analyzed very carefully a group of patients with these IgG3 kappa deposits. And turns out they're not clonal in a lot of cases. They're just a bunch of IgGs that happen to be using the same heavy chain and light chain isotypes. Next is a 60-year-old male with sort of markedly increased creatinine, proteinuria, history of diabetes, and hepatitis C. And I'm actually going to show you several biopsies from patients who happen to have hep C. And we heard Dr. Sohair Manzi's talk about hepatitis C and liver-related problems, but it can also cause renal disease or be associated with renal disease. Serologic studies in this patient have been normal or negative. So here's the biopsy, and this one's a little bit different from the other 3 that I've shown you so far. The glomeruli here do have what looks like nodular expansion of the mesangium in some areas, but they're also much more cellular than the previous biopsies. And here we have our PAS and Jones silver stains, and there are areas of glomerular nodularity there on the PAS, there on the silver. But again, the glomeruli look quite cellular. And going back to Sibyl's talk on Monday, for any of you who are here for that, there's this pattern of double contouring or tram tracking of capillary loop basement membranes that she showed very nicely. There's a good one up there, another one down here. And that not always, but often means that there are subendothelial immune complex deposits present. And indeed there were. Here's the electron microscopy. Basement membranes here actually don't look particularly thick, but here's a subendothelial immune complex deposit, and there's another one here. These didn't have any particular substructure to them. Here's a higher power view. Actually, from where I'm standing, this almost looks like it has a few little microtubules in it, but I think I'm deluding myself at this early hour. Strong staining for IgG and mesangial areas and capillary loops. This one has a good bit of C3, but no C1q, and the deposits are polyclonal. There's fairly equal staining for kappa and lambda chains. So this patient has an immune complex glomerulonephritis and an immunoproliferative pattern. It's consistent with a hepatitis C-associated MPGN type 1. Didn't see any objective evidence for cryoglobulinic glomerulonephritis. And have to sort of hold in abeyance the question of diabetic nephropathy here, because it did look like there were mesangial nodules, but the capillary loop basement membranes didn't look particularly thick. So this may actually be an example not of a dual glomerulopathy, but something entirely different. In this case, MPGN type 1. Okay, another hepatitis patient. This 59-year-old male, chronic kidney disease with generalized edema, anasarca, almost 10 grams of proteinuria, history of diabetes, untreated hepatitis C, and yet again, a recent use of an NSAID. So here is H&E stains at low power and higher power. And again, we see these relatively hypocellular mesangial nodules. The PAS stain shows the nodules. The capillary loop basement membranes look sort of thick. Now, the silver stain here has a different pattern. And again, this is something that Sibylle Damgaard talked about on Monday. If you look out around the outside of the capillary loops, in a lot of areas, there are these little whisker-like excrescences sticking up into the urinary space. And these are referred to as spikes. And in contrast to the tram track or double contour, these things usually mean that there are subepithelial immune complex deposits present. There's a kicker here, though, which is that there were well-developed spikes in some areas, and they seem to be totally absent in other areas. So this appears to be a segmental process. And that was borne out in the electron microscopy. This is one field that shows sort of thickened basement membranes, expanded mesangial areas. That all looks like what I've been showing you for the last 20 minutes. But then here's another area where there are clear-cut subepithelial deposits with little fingers of basement membrane material sticking up around them. And those are the spikes. So on silver stain, the light staining stuff here would be black, and the deposits, the darker staining stuff, would be lucent, so it's sort of reversed. Here's a nodule in the middle. And here is a higher power view showing deposits, and then all of a sudden they just sort of stop over here. Here's the fluorescence, shows bright staining in a granular pattern of capillary loops. There's a little bit of complement staining. And then maybe it shows up a little bit better here. Look at the kappa chain stain. There's bright granular staining in some loops, and then it's absent in others. Same thing for the lambda chain. So this looks like a segmental membranous nephropathy. And segmental membranous nephropathy is often associated with deposits that contain a protein called NEL1. So we sent off request for immunohistochemistry for NEL1 to our colleagues from the Mayo Clinic, many of whom are here. We don't have the stain in-house yet. And we see sort of clumped granular staining in this glomerulus and a minority of capillary loops. This one has much more staining. Again, it's segmental. A lot of staining up here. It's absent here. So this is yet another RPS class 3 diabetic nephropathy, but this patient also got clear-cut membranous nephropathy in a segmental pattern, and it appears to be a NEL1 membranous. There's a big differential of things that can be associated with NEL1 membranous. One of the first ones that was described was neoplasia, but there's now a big long list. Alpha-lipoic acid is one of them, use of skin creams containing mercury, but two of them relevant in our case here are it's been associated with use of NSAIDs, and there's a few case reports of it in patients with hepatitis C. So I think in this patient, it's one or both of those things causing the patient's problem. and the patient should stop using the NSAIDs, and maybe they should consider treating the patient for hepatitis C, since they're now good drugs for that. Okay, this is our final case. 53-year-old male, acute renal insufficiency, sort of lower level proteinuria, yet again hepatitis C, negative serologic studies. He had had a serum protein electrophoresis that didn't show an M protein. And this was an outside biopsy from a referral, and the history we had was a little bit fragmentary. I actually don't know if this patient had diabetes, but had a biopsy that looked like it was compatible with diabetes. Here's a nodule up here, another one over here on the H&E stain. Here, a mesangial nodule, sort of maybe a little bit cellular, but sort of within the range that you can see in Kemmel-Steele-Wilson nodules. And on the silver stain, they show up quite nicely, strongly silver positive. So I was thinking maybe this patient does have diabetic nephropathy. Well, the electron microscopy put the lie to that speculation, because here, over in the mesangial area, instead of just sort of light gray matrix material, we have this granular stuff. And I've shown you several granular deposits, but this looks qualitatively a little bit different. It looked like sort of fine punctate material that's not quite as uniform. And there is some of that here along a basement membrane, but shown better here. Here's a capillary basement membrane. You see these deposits that are sometimes described as looking like gunpowder or coffee grounds. Here's a higher power view of the stuff in the mesangium. You can see it's got this really fine punctate appearance rather than being uniform. And it's also in tubular basement membranes. No significant staining for immunoglobulin heavy chains, but there's sizzlingly bright staining for kappa and not lambda chains on the immunofluorescence. This patient doesn't have diabetic nephropathy. He, in fact, has light chain deposition disease, kappa chain type. And this is sort of a known look-alike for diabetic nodular glomerulosclerosis. And I think Sibel also showed some nice EM pictures of light chain deposits on Monday. Okay, so in conclusion, I would say that diagnosis of dual glomerulopathies involving diabetic nephropathy plus something else really, really begs for you to use all of the diagnostic modalities you have at your disposal. Light microscopy, immunofluorescence, special kinds of immunofluorescence, electron microscopy, immunohistochemical stains. Haven't spoken about it, but mass spectrometry is another option. Electron microscopy, as some of our speakers have already said in this conference, provides an open view. So you can see basically anything that's there. You don't have to select a reagent that's specific for a particular ligand. And that makes it particularly valuable. And finally, I mentioned this in my previous talk, you should pay careful attention to the clinical history, but don't let it lead you around by the nose. Sometimes something is missing, sometimes something is there and is misleading. So don't be a slave to Epic or whatever electronic medical records you use. So beware lookalikes. And with that, I'll stop.